Okay, everyone, good morning. Remember to please type your name in the chat. Please type your name in the chat. Good morning, everyone. Make sure you are on camera and sitting at a desk, not driving, not moving around. If I do see driving or moving around, I am going to take you out of class. But good morning, Mrs. Chubb. I see you didn't break anything this weekend. Good, all right, fantastic. Or maybe Ralph, that's why she's running late. She's probably breaking up everything.
Definitely.
Uh-huh. Miss Johnson, how you doing today? Oh, she might have stepped away for a second. Mrs. Hawthorne, come on the camera. Good morning. We still got a little bit of time. Before we start yellow highlighting. Make sure everyone is in the chat. Type it in the chat. Hope everyone had a good restful weekend. And we'll start at 9:01. There's Mrs. Medina. Good morning, Miss Medina. Hope you had a great weekend. Come on the camera. Everybody come on the camera.
Good morning.
You always look like you just stepped out of a model magazine.
I wish.
A fashion magazine, always.
I wish. Thank you, though.
You're welcome. Everyone have their coffee and their tea? Miss Momanya, you got your coffee or your tea?
Got it.
All right. Today's not a super long one, but it's interesting. It's interesting. Also, anti-infectives, rather, slowly but surely posting them because it's so many. So part 1 and part 2 are on your YouTube channel. Part 2, I think, is still buffering because it is a huge one. So just give it a little chance to buffer. But I put the link in there for you. But you can always just go to the YouTube channel itself and be able to see all of the videos. There's Miss Johnson. I just asked about you. Good morning, Mrs. Johnson.
Good morning.
How's my chicken nugget doing?
Tired.
Oh, I know. Get you some coffee. You got some coffee?
I don't drink coffee, but I do have my
You got some tea?
morning.
What's that?
Juice with a shot of B12 in it.
It looks like a margarita. Hold that up again.
I wish.
Let me see. Hold that up again. I don't know.
I wish.
Okay, so Miss Renisha, we're missing Miss Hawthorne. If you can go on the camera, Mrs. Hawthorne, and good morning to you. There she is. Oh, it's a little dark in there. Put a little light on so I can see you. There you go, slowly but surely. Turn some light on. Hawthorne, where do you get your skirts from, your nursing skirts?
You can order it at either Scrubs or Beyond, but when I went there, it didn't have it, so I just made it myself.
Okay, but they sell them on Scrubs Beyond?
Mhm.
Nice. I love the skirt.
Well, thank you.
So classic. Okay, we'll start in about 3 minutes, guys. So if anyone needs to make a last minute restroom run, make sure you type in the chat for attendance. Oh, there's Miss White. Yasmin, good morning. I see you pop in. Let's see you on the camera. Good morning to you. Miss Kyla, good morning to you. Good morning. There she is. There's my 2 chicken nuggets. How are you guys? Make sure you type in the chat for me. Oh, Yasmin, you look sleepy. Wake up, mama. Get you some coffee. Okay. All right, good deal. What about you, Miss Kayla? You doing good, Miss Kyla?
Yes, ma'am.
All right, you got your coffee? Say it again, you went mute.
Oh, no, ma'am. I don't have no coffee.
Okay, well, you got some tea, something? All right, well, get some water then. That'll keep you hydrated. Mr. Aaron, good morning to you, sir.
Good morning.
Good to see you. Always a pleasure to see you.
Likewise.
Even though I can't see you, actually. Don't forget to type in the chat. Yeah, it's dark and you have the cover. Maybe you have the cover.
Not to find you. Let me see what's going on here.
Don't worry, Chubb broke it. She broke it early this morning. Okay, let's see who else are we missing. We're gonna start in about a minute. And then I'm gonna start green highlighting everybody. Miss Ralph and Miss Brockers, good morning. Good morning. Don't forget to type in the chat. Good morning, folks. Good morning. I'm so glad to see your faces. Miss Brockers got on her cute hat. I like it. It's the get down to business hat. Ralph, how's the kids?
On my nerves.
Well, yeah. Right in front of their faces, huh? Just gonna tell them right in front of their faces, huh?
I need them to know that they get on my nerves.
Oh my goodness. Oh, poor pumpkins. Okay, we have 1 more minute and we're gonna start. Make sure everybody types in the chat. Oh, there's Miss Emerald. Good morning, Miss Emerald. Make sure you're on camera and stationary sitting somewhere. Good morning to you. Oh, there's Miss Talise. There's Mother Chicken Nugget. Good morning, Miss Talise. How are you? And Miss Yara, good morning. Good morning.
Good morning.
Make sure you type in the chat, everybody in the chat. And make sure you are stationary and sitting. All right, I'm going to get started. Everyone else after this point is going to get the green highlighter, okay? And today we are covering respiratory. Make sure everybody's in the chat and on the camera, just making sure everybody is accounted for. Emerald, you're not on the camera yet, dear. Still taking attendance. Miss Emerald, you're not on the camera, dear. And Miss Singleton, I saw you on the camera, but you disappeared. Do you have two things open? Miss Singleton? Okay, there's Miss Ashley. So like I said, green highlights. Anything after 9:01, we're gonna mark absent. Make sure you sign into the chat. And Miss Singleton, there we go. And Miss Emerald, you're still not on the camera.
She said she's switching over to her computer. She said that in the chat.
Oh, okay, all righty, okay, no worries. Make sure everybody has typed into the chat in order to get credit for being here today. That's where I pull the attendance from. And no Miss Williams, no Kiwana. And Singleton, I saw you. Okay, what about Miss Brooks and Mrs. Castillo? I don't see Miss Brooks. I don't see Miss Castillo. All right, so green highlight it is until everybody shows up. So good morning, my chicken nuggets. Everyone, you can type into the chat. Oh, that sounds just not really encouraging. But let's go ahead and sign. We're gonna play a game, all right? So let me go ahead and share my screen and we're gonna play a game to get the morning up and rolling. All righty, so feel free to type it in the chat. All righty, so hold on, let me pull up the chat so I can see the answers. Okay, so what you do, guys, is you're going to identify these objects. They are almost at the microscopic level. So go ahead and type into the chat what you think these items are, ladies and gents. Ready? And go. What is this item? And don't cheat. Y'all cheat and look at each other's answers. What is that, ladies and gents? Go and type into the chat. Okay, we have cheese, we have a pencil, we have an orange, we have some butter. What kind of butter is that, Ralph? It's some new butter, okay. We have a pencil, Any other choices? A honeycomb, all right. Okay, so let's keep moving, guys. Somebody said a mango. A mango would be so good right now, wouldn't it? All right, here's the next one. What is this, ladies and gents? What is this? An AC vent, cell phone, an air vent, blinds. All right, we got some good choices here. Okay. All right. Okay, so let's try the next one. What is this? Because somebody said, I don't know. I don't know either, Ms. Brockers. All right, let's look at this. What's this, guys? What on earth is this? Miss Hawthorne working hard. Look at her. That brain is working. I smell the smoke. What is this? That's a tough one, huh? I'm not sure what that is myself. A door hinge? Okay, that'll work. What else? Anybody else got any other ideas? Drums, okay. Ceiling. What else you got? No clue. A carving, a doorknob. All right. Let's move on to the next one. What is this? Peephole. Well, the peephole might have been for the last one, but what's this one, guys?
Maybe a lock mechanism?
Type it in the chat, but a lock. Okay, we got a wrench. We have a tool, that'll work. A lock inside of a sharpener. Oh, that's a good choice. Some sort of tool, a door stop, an industrial belt. Oh, we got real in-depth there, Mrs. Chubb. A lock. All right. I can't even remember what these things are. All right, let's move on to the next one. What's this? Looks creepy. Earwax. Oh.
I don't know.
A flower, a dead flower. That'll work. A stem, an apple stem. Good choices.
Mold growing on like an apple core or something.
Type it in, type it in, type it in, Miss Castillo, type it in.
Thank you. Turn your mic off.
Okay, sorry.
Stem, mold. All right, we got some good ones. All right, let's keep it moving. What is this? A cigarette, ice cream, mold, fungi, something burning, cigarette, ash from a candle, that'll work. Wood on fire, cigarette. Okay, let's keep going. What's this? Toothbrush. Toothbrush, toothbrush, hair follicles, toothbrush, straws, brush. All right. Got a lot of brushes. All right, what about this one? What's this? Scab. Looks like one, huh? An Oreo cookie. That's what I think, but with a hair on it. That looks like a hair, right? I don't know. Oreo cookie or chocolate cake with a hair on it. Ugh. Cake. All right. Some kind of dessert, Oreo cookie. All right, let's keep going. Get two more. What is this? Oh, somebody said a special brownie, pod brownie or something, huh? For the special occasions. A bell pepper, a tomato, mold on a bell pepper. Okay, that'll definitely work. I see some little things going on there, huh? A tomato. All right. Okay, somebody said wax. Okay, and next one. What's this one? A lock. That sounds good. Anyone else? A grinder. Inside of a lock, a lock. All right, turning mechanism. Okay, so let's get the answer. Oh, we have one more, sorry. What's this? A dryer sheet, some rope, some cotton, cotton. All right, good job. A blanket. All right, good job. All right, you ready for the answers, ladies and gents?
Yes.
The first one was a pencil. Woohoo!
Yes.
The second one was a razor. The one you thought was a vent is a razor. The third one was a key. It was a key. The fourth one was a lighter. I guess the top part here where you strike it to start the lighter. Then we had the top of an apple, so the stem. Good job. You guys are doing really, really well. This one is a cigarette. Miss Emerald, you said cigarette, didn't you? I think you said cigarette. And then toothbrush. A lot of you guys got toothbrush. And Oreo cookie with the hair on it. Then we had a bottle top. I think that was the one that we thought was the red mold. They looked like the pepper. And then we had a wrench, I guess the geared mechanism of the wrench. And then that one we thought was cotton was a tea leaf, a tea bag rather. All righty, so just a couple of reminders, ladies and gents. You have your Canvas respiratory quiz that's going to be due this Saturday at 11:50. Please try not to wait to the last minute if something goes wrong on the weekends, because I am not available on weekends. So if anything goes wrong, you're gonna have to reach out to one another. So please don't, please try to not wait until Saturday to do these assessments. All righty. All right, so let's talk a little bit about the respiratory system, and this is chapter 15 in your book, and these are your objectives. So we're going to discuss the major functions of the respiratory system. We're going to go through several of the organs that are included. We are going to compare, contrast, and explain the mechanisms behind the exchange of gas for internal and for external respirations. We're going to discuss the volumes of air that are exchanged during ventilation or breathing, and we will also discuss the mechanisms that regulate breathing itself, okay? So let's start with the anatomy portion of the respiratory systems. Before I get started, did anyone have any questions, concerns, or issues? Okay, now as we're going, remember, I'm gonna have you guys unmute because I'm gonna be throwing questions at you. So go ahead and unmute yourself. If it's not too loud in the house, go ahead and unmute yourself, or I'll be calling on folks as well, okay? So let's talk about the upper respiratory tract. And the first thing I wanna cover is the nose. Now why, ladies and gents, does the nose play a role in the respiratory tract? Come on, shout out, let's hear it.
Because that's where the air
Smell.
enters the body.
Right, so absolutely. So the air enters the body, most part, if you're a nasal breather, because usually kids are nasal breathers and adults become a little bit more mouth breathers, but it ideally comes in through the nose. So as air comes in through the nose, what happens to air, ladies and gents? Talk to me about it. What happens to air as it comes in?
Cilia in there.
Filter.
It gets what? It warms up?
Filter.
It filters, it warms up because the nose has capillaries in it and it warms the air up. It filters because we have little hairs in our nose, right? So they work to kind of trap any kind of, well, not even pathogenic, but it can trap bacteria, viruses, dander. It hopes to trap any of those things, right? What else do we utilize our nose for?
Smell.
Smelling, right? So it also gives us an indicator to interact with our environment by smell. Absolutely. So as we move down the nose, we move into the pharynx, and the pharynx is divided into three main sections: the nasopharynx, the oropharynx, and the laryngeal pharynx. Once again, the pharynx is divided into three sections: the nasopharynx, the oropharynx, and the laryngeal pharynx. Okay. The nasopharynx, ladies and gents, is right behind the nasal cavity. So it's the first portion of the pharynx. Then we move down to where the mouth comes in, the oropharynx. And then as we move down a little further, we have that laryngeal pharynx. Okay, so you see how the nose, the mouth, and the throat itself are connected? That predisposes and also may explain why we get, respiratory infections either through the mouth, through the nose, or if we don't wash our hands and we eat something and it has, cooties on it, it can go into the mouth and ultimately down into the respiratory tract. Picking up what I'm putting down? All right, beautiful. So as we go further down past the pharynx, we have the larynx. We have the larynx. And the larynx is what kind of how do I want to say it? It is the opening or the conduit from the pharynx into the trachea. Okay, once we hit the trachea, we're now moving into the lower respiratory tract. Now, just keep in mind, from nose to all three pharynx into the larynx, that is all one form of mucousy tissue. It is all connected. which is why when a bacteria or virus gets in, it makes it a lot easier to facilitate its movement into the respiratory tract. But luckily, your body has all sorts of mechanisms that will work in order to kill these particular microbes, right? So you have mucus that happens to, that will help to fight. You also have, remember we talked about lymph. You have lymph nodes that are in this area. So if that pathogenic bug gets in there, the lymph areas are gonna hopefully work to kill that particular bacteria. You guys got me?
Mm-hmm.
All right, fantastic. So now let's move into the lower respiratory tract. Now I like to think of the lower respiratory tract as an upside down tree. So imagine this guy is standing on his head, okay? The big branch of the lower respiratory is called the trachea. The big branch of the respiratory is called the trachea. So think of that like the trunk of the tree, okay? And then from the trachea, we have this large area here, which is called the bronchi, okay? And then our lungs in turn branch off into these little smaller tubules, which are called bronchioles, okay? So you see it kind of looks like a tree where we have big trunk, then we have smaller branches, and then we have even smaller branches, okay? At the ends of the bronchioles, ladies and gents, we have these little small sac type of vessels, I don't want to say vessels, structures. And they look like a bunch of grapes. So think of them kind of as a bunch of grapes. And around that bunch of grapes that circumnavigates that bunch of grapes are these little things called capillaries. These are called pulmonary capillaries. This is the site, ladies and gents, of air exchange, right here in the alveoli. So what happens is oxygenated blood comes in through these pulmonary capillaries, and then they in turn exchange that oxygenated blood to deoxygenated blood, and it sends it back up to the lungs so that the person can take the next breath and repeat the process. Does that make sense? Now, the way that these pulmonary capillaries stay open is by the alveoli remaining open. They are little air sacs. So patients have to continue to deep breathe and cough to clear out the airways to keep these alveoli open. So let me ask you this. Let's use some critical thinking. If a patient's alveoli collapse, and I'll talk about some different reasons why and what that's actually called. If the alveoli collapse, what do you think are going to happen to the patient? Let's talk about it pathophysiologically. What may happen to the patient?
Respiratory distress.
Okay, I dig it. And talk to me about that. What's going on that they would go into respiratory distress? Because what do the alveoli do?
Because they filter out the
gas exchange.
right.
The site
the
of gas exchange. Absolutely.
So because it filters it out and it's not able to filter it out, then they wind up becoming, what's it called, hypoxic or something like that?
Well, they'll be hypoxic or hypercapnic. But remember, the alveoli, think of them like a balloon. They have to stay open. And when they stay open, they keep the pulmonary, I'm sorry?
Like a collapsed lung.
Like not a lung, but let's think of it more on the alveoli level, because you can have a collapsed lung, but we're thinking on the alveolar level. So these little tiny, think of them like little grapes or little balloon sacs. They have to remain open. When they stay open, the capillaries stay open. So can you guys see my little arrow thing here? You see me moving my arrow?
Yes.
You know, okay. So you see these are little sacs, right? And around the sacs are these capillaries. If the sacs close, what do you think happens to the capillaries?
They get squished. They
They
can't,
get pushed and turn to and flatten. And
don't allow for oxygenation.
There you go, Ms. Castillo. It also not only does it not allow for oxygenation, you can't convert it. So you can't take that deoxygenated blood and turn it back into oxygenated blood because we have flat capillaries. Picking up what I'm putting down?
Yes.
Yeah.
All right, so as nurses, it's your job to maintain the alveoli integrity. And I think I talk a little bit more so about that when I get to the lower. I do. When I talk a little bit more so about the lower respiratory, we'll talk about keeping those alveoli open so that the pulmonary capillaries can remain open. Okay, also on top of those alveoli, we have the lungs themselves. Now the lungs are muscular tissue. Human beings have two lungs with different lobes. So the right lobe has how many right lung has how many lobes?
3?
3 right here. So we have lobe 1, lobe 2, and lobe 3. The left lung, on the other hand, only has
2.
2. And why does it have 2? Why does it get the short end of the stick?
The heart.
It has to accommodate the heart. So your heart, if you can see the little arrow, the heart is going to sit right about here. So it has to accommodate that heart. Does that make sense to you guys?
Yes.
All right, you guys are doing awesome. Did I lose anybody? Everybody still with me?
Yes.
All right, good deal. Okay, so let's move on. All right, so let's talk about that mucosa. So remember I mentioned from the mouth, the nose, the pharynx, and the larynx, even down into the trachea, there is one single membrane, one single thin layer of tissue that covers the respiratory system. Now, it can be a good thing or a bad thing. It's a catch-22. Sometimes if there is a bacteria that goes in the nose or the mouth, it will predispose the patient to developing a lower respiratory infection if all of the mechanisms above that area do not kill that cootie. Does that make sense? So now that the respiratory mucosa contains a lot of mucus, okay? And it forms sort of like a mucal blanket, okay, that inundates and kind of saturates the mucosa itself, okay? Now know that even within that mucosa, there are cilia, and cilia are little tiny microscopic hairs, absolutely, and they bend in one direction. They bend in one direction, and they bend upward. The reason that they bend in one direction and bend upward is if there happens to be a cootie that goes into the lungs. The cilia hope to move upward and pass the cootie back up and out of the body through the nose or the mouth. Does that make sense?
Yeah.
Yes.
Right, because your body is designed to try to protect itself as best way it can. The mucus also helps to trap dust and pollen. If the nose doesn't get it, it'll hopefully trap dust and pollen, and also hopes to trap bacteria. All right, you got me on the mucosa? Yeah, now?
Yeah.
All right. Okay, let's talk a little bit about the upper respiratory system. Okay, so like we said, we have one nose that contains 2 holes. We call those holes nares, N-A-R-E-S, nares. And the septum, the nasal septum, separates the both of them. As human beings, we tend to breathe through one heavier than the other, and it does alternate. So, you know, you don't necessarily have to utilize the right one more so than the left. It's going to alternate. The nose takes turns doing both. The nose itself has mucous membrane that goes all the way down. And the purpose of that membrane is to trap bacteria, trap dust, trap anything that's not supposed to be down there. And of course, you have the cilia pushing it right back up. So that's why sometimes if you happen to get like a allergen or a dander and it irritates and tickles that nose, your instinct is going to be to sneeze with the expectation of getting it out. Does that make sense to you? That's why you sneeze, to get it out. All righty, so what did we say the functions of the nose, the nose is?
Smelling, breathing.
Smelling, breathing. Mm-hmm. What does it do to the air? Filters it, warms it.
Mm-hmm.
It can even sometimes cool it if it's too hot outside, right? Okay, now there are different sinuses that sit behind the nose and drain into the nose. I'm gonna show you a picture of that in just a sec. Here are your sinuses, ladies and gents. Does anybody suffer from sinus headaches or sinus flare-ups or sinusitis?
I think everybody in this class.
All the time.
Everybody, this is just Houston, right? I don't know what, Houston just has so much dander and it's so moist and humid. So everybody in Houston automatically comes in with the sinusitis. So now this, I'd like to now explain the pathophysiology behind sinuses, right? So on the top of your head, ladies and gents, you have those frontal sinuses. So what happens is as that allergen comes in, so can you guys see my little wiggly arrow?
Yeah.
Okay, so we go outside, right? We're all going for a jog because we're getting in shape, and we encounter some grass. So the dander or the allergens from the grass go into the nose. And as it goes into the nose, it's going to be stopped by some of these sinuses. Because remember what we said when we talked about lymph. When something foreign goes into the system, the body activates, starts sending white blood cells, starts sending antibodies to that area to attack whatever does not belong in the body, correct? All right, so that we have the allergens that come in from the grass, and it'll say hit the frontal sinus, and it goes into the frontal sinus. At that point, when it goes into the frontal sinus, same thing occurs. So mucus is going to go to that area, lymph is going to go to that area, white blood cells are going to go to that area, and it's going to build up pressure. And when it builds up pressure, what do you guys have after that?
Sneeze. Oh, headache.
Headache.
Or you'll
Sinus
develop
headache.
what else? Or you may develop a
Sinus infection.
sinus infection or even a sinus headache. Even a sinus headache. So when you do have those allergens and you start feeling that pressure over that eye, that's probably what happened. Picking up what I'm putting down? All righty. Underneath this, we also have the sphenoid sinus, and it sits right between your eyes. You may feel a little pressure in between your eyes. And that's what's happening. That allergen got in there, those antibodies are trying to fight it, and it's causing a little war going on in there, okay? Also, same thing here. We have the maxillary sinuses that sit right on your cheek, kind of on the inside of your, on the outside of your mouth, but toward the cheek. So sometimes you may have some built up or some pain there. When you guys did health assessment with Mrs. Duhan, did she talk about palpating the face?
Yes, we did.
Yeah.
Fantastic. So that's why. So you're feeling, you're feeling on these sinuses of your patients to see if there's swelling or if there's discomfort. If you know there's swelling or discomfort, then perhaps they're dealing with some kind of infection, even local irritation in that area. Does that make sense?
Yeah.
All righty. So once
I have
again.
a question.
Oh, yes,
So just because that it's inflamed doesn't mean it's infected, right?
That is correct. Inflammation just means that it's irritation to the area. It does not have to be infection. Now here, let me explain it like this. Something can be inflamed and infected. Something can be inflamed or something can be infected. Does that make sense? Infected just means that it has a microbe involved. Inflammation just means that it's redness and irritation to that area.
Yes.
So in this instance, they can have sinusitis where it's irritation, but it's not necessarily infection. So you'll have sinusitis if you're dealing with maybe an allergen, because that's not really a bacteria. That's just something that your body is creating antibodies to fight. But if you got a cootie, you know, your kids came from daycare and everybody sneezed on them, they came home, sneezed on you, and it happens to be a bacteria, then you may have inflammation and an active infection as well. Okay, got me?
Yes.
All right, guys. So once again, there are the three main paranasal sinuses. We have those frontal, we have the sphenoid, and we have the maxillary, okay? So kind of make sure you take a look at those things. Know your frontal, what's going on there, your sphenoid, and your maxillary. Okay, you got me? All right, let's move on. We're gonna move down a little bit. Let's talk a little bit about the pharynx. Let's talk about the pharynx, okay? And remember, we said the pharynx is divided into 3 sections. What were the 3 sections that we talked about that it was divided into?
Nasal,
Oral,
Pharynx and
oral, and
Larynx.
laryngopharynx. Good.
laryngeal. I couldn't say it.
Oh, we know what you meant, baby. So in adult humans, it's only about 5 inches long. It also, not only does it act as a respiratory, it acts as a GI organ because food passes through it. So like we said, the first section is nasopharynx, second section is nasopharynx is at the nose level, oropharynx is at the mouth level, and laryngopharynx is closer to down to your to the laryngeal area, okay, into your larynx. So there are 2 nasal cavities, okay? The 2 nasal cavities, your mouth, your esophagus, your ears, and your larynx all open to the pharynx. So let's think about that critically, guys. We have a nasal cavity, and nasal cavity is open to the outside, right? We have the mouth, opens to the outside. The esophagus opens to the outside through the mouth. The auditory tubes, which are in your ears, your eustachian tubes, or auditory tubes, open from the outside. Can you see why little kids get infections so rapidly?
Yes.
Their little noses, their little mouths, their little esophagus, their little eustachian tubes are very close together because they have little tiny heads. And what do little people do when they have an item, a dirty item?
They put it in their mouth.
They put it in their mouth, they rub their nose, they pull on their ear. This is how they're, and on top of doing all of those things, they have little, very immature immune systems, right? They have very immature immune systems. You guys remember the two different immune things that we talked about? Innate and natural and, come on, somebody said it.
Active.
Artificial.
Artificial, right? We got innate and artificial. So we're dealing with little people. They have their own little innate immune system. They may get immune system from mom if they're breastfeeding, and then they get immune system from, some kind of immunity from artificials, right? When they get the shots,
right?
MMR and all that other good stuff, right? Okay. Now remember, the mucous membrane lies within the larynx. So as that cootie is migrating down, we do have those cilia that hope to push it back up so it doesn't get into the lower respiratory area, because that's the worst it can do. We don't want it. We want to keep it up, because if it's up and higher in the respiratory system, we can sneeze it out, cough it out, we can get rid of it. But when it goes down further, that's when we're starting to deal with flu and pneumonia. That's when we're dealing with the big dogs, okay? The purpose of the pharynx is passage of food and also airway. Passage of food and airway. Passage of food and airway. All right. You guys got me?
Yes.
All right, let's move on down. We're moving into the larynx. Now, the larynx is a complex piece of machinery, for the lack of a better term. It is held up by what we call C rings. And these little C rings are pieces of cartilage. Do I have a picture of the larynx? I'm gonna go back, guys. I wanna show you this picture. I thought I did, okay. So if you can kind of see here, this is the larynx, even though it is a cross section. And just think about it as being a little C-shaped cartilage that hold it open. Little C pieces of cartilage that hold it open. I'm gonna go back, okay? Alrighty, so these little pieces of cartilage hold the larynx tissue open. Almost to the top of the larynx, there is one piece of cartilage right at the thyroid area that is usually larger than the others, more prominent in men, and it's called the Adam's apple. Right, so that is actually a piece of cartilage that holds the larynx open. It is more pronounced or larger in men. At the top of the larynx, we have a flap of skin that looks kind of like a curtain opening and closing. It's called the epiglottis. Okay, it's called the epiglottis. And the epiglottis opens and closes as needed. But as you're eating, it closes. But sometimes, have you guys ever eaten and somebody said something funny and it goes down the wrong way and you start to have a little choke?
Yes.
That's the epiglottis opening when you're eating, and it should not be opening when you're eating. So let me show you pictures of the epiglottis. Here it is here, right? Here's the epiglottis, right here's the epiglottis. It should not be open for the most part when you are eating. When you're talking, yeah, because it helps to vibrate those vocal cords. But when you're talking, it should be open. When you're eating, it should be closed. But sometimes what happens is, as you're talking and eating, it opens, the epiglottis opens, pulls those vocal cords, and food may go in, and it'll cause you to have a little bit of a choke, okay? Now know that the vocal cords, I'm gonna put this back up, the vocal cords stretch through the larynx, okay? So here is the larynx. Think about the larynx is right up on top here. Right here are your vocal cords, and they vibrate as you speak. So these guys are gonna vibrate, 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 vibrate as you speak. So here's another little picture of it here. Here's your vocal cords. The epiglottis sits right here. And remember, as you eat, it's gonna close. So here is the trachea, here is your esophagus. So let's say this is a side view of a person, and my arrow is food. So it's going to close up this way so that it can facilitate food going in this direction, right? Because food should be coming down here. Food, 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 food. Air comes down here. Do, 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 do. But if something goes down the wrong way, our bite of chicken goes instead of into the esophagus, it may go into the trachea, therefore causing you to cough. Does that make sense?
Yes.
All right, good job, guys. Did I miss anything? No, okay. All right, so let's now move on to the lower respiratory. Did anybody have any questions at all as we're moving on?
No.
You're good? Okay, good,
Good.
good. Let's move on to the lower respiratory. So once we hit the trachea, we're now into the lower respiratory region. The trachea is only about 4½ inches long, and it reaches from the larynx and goes into your thoracic cavity. And remember, it too, just like the pharynx, just like the nose, just like the mouth, are all covered with this exact same mucus lining. The trachea too is held open with those C-shaped cartilage rings, with those C-shaped cartilage rings. Okay. And the function of the trachea is the facilitation and passage of air. It's your windpipe. It's going to move air to the lungs, or oxygen to the lungs, and CO2 from the lungs. Okay. So what happens if the trachea becomes occluded? Something blocks it. What happens?
Can die.
If it stays occluded, absolutely, absolutely.
You start to cough, like.
There, that's what I'm looking. You're going to start to cough because your inkling is to try to expel it, right?
Right.
Okay, so if you see somebody and they're eating their little Big Mac and they start to choke and their trachea becomes obstructed, what do you do? What do you guys do as interim and nascent nurses? What are you supposed to do?
Hit them on the back or the Heimlich maneuver.
Heimlich maneuver. If they're an adult, right? So you want to go ahead and get the Heimlich maneuver in. And where do you play? How do you talk me through the Heimlich maneuver? How do you situate yourself for that?
Behind them.
You're going to stand behind them, absolutely. You're going to place your arms around their abdomen, correct?
Mm-hmm.
You're going to put a thumb with the top part of the, I'm sorry, your fist with the top part almost at the belly button. The other arm is going to hold onto that fist. And then how are you going to push?
Push upward.
You're going to push upward because what
Upward.
you want to do is the change in pressure hopefully will dislodge that food, boop, and shoot it on up. If they're gagging and making noise, can they breathe?
Yeah.
Yeah.
If there's sound coming out, they can breathe. Not well, but they can breathe. At the point
Right.
that you don't hear any sound, that's where I want you to start. Well, I don't want you to panic, but that's where I want you to start getting concerned. Okay? How long can a person go without air?
3 minutes.
3 minutes on an average, right? So death can ensue in minutes. So as new nurses, it is imperative that you act rapidly. When someone is choking, what do they normally do? What's the action that they tell you I'm choking?
They put their hands around their neck.
They put their hands around their neck or point to their neck. So that would be an indicator that, hey, something's going down the wrong way. How do we clear the airway for for our babies?
Turn them on their back and pat their back
With your
towards
finger.
up,
Upside down. If it's a small
upside
like,
down.
baby, you're gonna turn them
Yes.
upside down, like, and put them like between your knees almost, and give them
Uh-huh.
brushes on the, give them
Brush on the back, moving
On
forward.
your hand.
moving forward, and then flip them over and do the same thing on their little belly.
Yeah.
Right? Okay, good deal. Okay.
I learned that in CPR a long time ago.
Oh, man, well, I'm glad it stuck with you. So make sure you guys will be taking your CPR so you'll learn this as well. Okay. All right, so here is a cross section of the trachea itself. And as you see, it's pretty complex, right? We have that mucus coat, and then we have a musculature here. It has an outer lining. We then have the C-shaped cartilage rings. If you can kind of see this gray piece right here. This is the C-shaped cartilage ring that keeps it open, Okay. And as you see, this is a great cross section. I love that it's here. When you're swallowing, you can kind of see the esophagus opens because it has to swallow, right? So it's gonna go ahead and open the esophagus because food is coming down. When you're breathing, you don't need to eat. So the esophagus is in turn going to close and narrow itself. So the moral of the story is no eating, no talking while you're eating, right? All right, so let's move on down to the bronchial tree. And this is the big branch that I was referring to. This is the big branch that I'm referring to, okay? All righty, well, you know what, let's go ahead and take a break. Let's go ahead and take a break because we've been going about 40 minutes. Let's go and take a break. Everybody come back at 9:55, 9:55, okay?
Okay.
9:55.
I'm here, Dr. Ross.
Oh, okay, no problem. Give me just a minute, guys. I'll be right with you. All right, babies, if you can type back on in the chat, I'd appreciate you. And let's hammer this home. Make sure everyone is on the camera. Miss Ellaby on the camera, Miss Kiwana, Miss Ralph, Miss Brockers, Momani, make sure everybody is back on and live in color. And let's hammer the last little bit of this home. Okay, Miss Kiwana, I can't see you yet. Emerald, I can't see you. And make sure you type back in the chat, guys. Make sure you type back in the chat. Miss Emerald, I can't see you. Is she restarting her computer, anyone? Did she let anybody know she's restarting again? Okay, did she respond? Okay, we'll put her back in the waiting room. Okay, she's not on camera. Okay, so let's go ahead and start. Let me share my screen with you guys. Okay. All right, so let's go and go talk about our bronchial tree there. All righty, and the trachea, underneath the trachea, we have our bronchial tree. So that's where we have that upside down sort of tree looking thing where you have a right and a left bronchi, and those are those large branches, okay? And from the bronchi, we have smaller little branches, okay, that are called bronchioles. And at the end of those bronchioles, we have the alveoli. So I guess, you know, it might be better to utilize the analogy of maybe a broccoli, right? So, you know, you have the big part of the little broccoli spear, then you have the little smaller parts of the broccoli spears, and then you have the little dark green little pebbly things on the ends, and those are acting like your alveoli, guys, okay? Now the alveoli, as we said, they're like grape clusters, and they are designed to remain open. They're supposed to stay open. And when they stay open, the capillaries that go around them, those alveolar capillaries that go around them, are the sites of gas exchange. Okay, so the alveoli are the sites of gas exchange. The substance surfactant is what helps to keep those alveoli open. Once again, surfactant helps to keep those alveoli open. And what it does is it reduces the surface tension of water and keeps it open. Does anyone have a preemie? Anyone had a preemie baby? Anyone have a premature baby or know someone who has? Okay, sometimes with preemies, their lungs are the last things to develop, and they're unable to develop or make surfactant, which is what's responsible for keeping their airways open. So that's why a lot of times when preemies come out, docs have to shoot them up with a lot of surfactant to allow those alveoli to remain open, to remain patent, and therefore potentiating that exchange of gas, okay? So that surfactant is needed in order to keep the alveoli open. So as we mentioned, when the alveoli close, that surfactant or mucus gets stuck in there. And when that surfactant and mucus gets stuck in there, we can't get air out. And if we can't get air out, CO2 levels are going to raise. In that instance, our patients become what we call hypercapnic, and their CO2 levels become high, and then can ultimately become dangerously high. Now, as nurses, the way that you promote alveoli opening is by deep breathing, coughing, and ambulation. Let me say that again. Deep breathing, coughing, and ambulation, and that's going to keep those airways open. Also, if the airways close, ladies and gents, that is called atelectasis. Your book might have talked a little bit about it. Atelectasis, in which those alveolar sacs are going to close and flatten. They close and flatten. Surfactant mucus gets stuck in. The alveolar capillaries cannot exchange gas, and we have patients begin to go into all sorts of respiratory distress, becoming hypoxic, becoming hypercapnic, and ultimately going into respiratory distress. So let's go ahead and review as nurses how we preventing atelectasis. What are we doing?
Ambulation.
breathing.
Deep
Ambulation.
Deep breathing,
Coughing.
confident.
coughing. Also, for my CNAs, have you guys ever utilized or seen for your patients the incentive spirometers?
Yes, I had to make my mother do it because she was being stubborn.
Right, because sometimes it's just a pain in the keister to remember to do. But as nurses, you guys have got to push your patients to utilize those. And do you guys know what the incentive spirometers look like?
Is
Is
it a
that the
little
thing where you
plastic
suck it
with a
up,
ball
where you
of
suck up the air?
It is. Let me pull up a picture of it real quick. Hold on, I'll pull up a
I
picture.
use it sometimes when I feel a little tight because I have asthma.
Oh, okay. Okay, well, that's a good thing.
Yeah.
Okay, so it looks like this. You've probably seen them and don't even realize you've seen them before. Okay, so it looks like this little joker here, right? And we have them by the bedside, usually respiratory therapy, or you, doesn't matter.
You're not sharing it.
Say again?
You're not sharing it.
Oh, well, why aren't I sharing it? Why
You
didn't
got to click that screen to share
I
it.
know why y'all didn't tell me I wasn't sharing. Okay, am I sharing it? Y'all trying to
Yes.
confuse me. All right, here we go. Okay, so it looks like this.
Yeah.
You can set a goal for your patient or respiratory, and what the patient has to do, they put their mouth around this. They're going to breathe out before they put their mouth on it. They're going to breathe out and expel all the air in their lungs, put their mouth on it, and then breathe in as hard as they can. And they're going to try to do that at least 10 times every hour. So who do you think, which candidate or what kind of patient or what disease process do you think you would really want to promote an incentive spirometer?
Like bronchitis or pneumonia,
Bronchitis, pneumonia, what else?
COVID.
Yeah.
COVID, okay. Respiratory infections, okay.
Tuberculosis,
TB, okay.
emphysema.
Emphysema, anything respiratory wise.
Mhm.
Also, our post-op patients. So those
Right.
patients who have recently had anesthesia in their lungs,
Oh, yes.
definitely, that's the best way to expel all of that anesthesia. So deep breathing, coughing, and using that incentive spirometer is definitely going to make it. All right, so what's the site of air exchange, gas exchange?
Alveoli.
Alveoli.
Alveoli are the site.
Alveoli.
Absolutely. Also, the alveolar ducts. Now, in between the alveoli, so you see we have alveoli, and then in between them, we have these little ducts, these little openings. You see what I'm talking about? These little openings?
Yeah.
Those are the smallest air distribution tubes. Those are the smallest air distribution tubes. So air is going to go in between these alveoli, and they also permeate through, or diffuse through the alveolar capillaries. So once again, we have the alveolar ducts. Those are the smallest sites of airway exchange. We want to keep these guys open. And what substance keeps the alveoli open?
Surfactant.
Surfactant keeps those airways open. Good job, guys. Y'all ready to take the test?
All right.
Fire.
Hold on.
You guys are on fire. Okay, do I want to talk about this? Nah, I don't want to talk about that. I don't care. Let's move on to the lungs, ladies and gentlemen. Let's move on to the lungs. So as we know, human beings, we have two lungs, left side and right side. Can we live with only one lung?
Yes.
Anything that has a pair, we can live without. So that's just a general rule of thumb. Now, that's not to say your body will work as effectively as God made you, but anything with a pair, you can live without, all right? So let's go ahead and talk about the size of our lungs. The size of the lungs, it usually fills up a majority of your lung cavity. So they're relatively big, right? The lungs are relatively large in size. Okay, and then I want to talk a little bit about the different parts. The apex of the lungs are these top parts, the apex of the lungs, and they sit kind of under your collarbone. The apex of the lungs sit under your collarbone. And then we have the base of the lungs, and they rest on top of, there's no picture here, they rest on top of the diaphragm. So the diaphragm is a muscle that sits right underneath here. So if you can follow my little arrow there, sits underneath there, and it's what's going to push the lungs up and push them down. Push the lungs up and push them down, okay? Now know that the lungs don't only have tissue, they actually have sacs around them. So let's think about, excuse me, let's think about we have a lung here, and then we have a very membranous, very thin sac that sits along and around this lung. And in between the sac, think of it as a sac having two layers, there is pleural fluid that sits in between. So why do you think the lung would need a sac that has fluid wrapped around it? Kind of think about that critically.
For movement.
To
It
keep
helps
it.
with movement. What else?
Protection.
Protection and movement.
Protection, absolutely. Protection and friction. So as you're jostled around on an on an airplane, or you're jostled around on a roller coaster, it provides additional protection. Okay. Now, sometimes, unfortunately, that pleural tissue can get infected. Say, for example, you got a patient got a gunshot wound and they get popped in the lungs with a bullet. And last time I checked, bullets are not sterile, right? They're pretty not clean. And then that particular area gets infected. So we start having pleural effusion, or a lot of fluid building up. And what do you think would happen if that fluid began to build up? What'll happen to the lungs?
Compresses.
So it'll put pressure on your lungs.
It'll start to crush the lungs. Picking up what I'm putting down?
Yeah.
Can you repeat that one more time, Dr. Ross? What you
I
said?
sure can. The pleural space, remember it's a sac.
Mhm.
If the pleural fluid begins to get infected, and we'll talk about that, like it's what it's called, and when there's white pussy fluid, it's called empyema, and we'll talk about that. We're not gonna worry about that right now. But let's say that there's a whole bunch of fluid that builds up in between that pleural space. What happens to the lungs as that fluid begins to build up? The lungs are going to begin to get smushed and crushed.
Compressed.
They're going to get compressed. So how do you think your patient's going to present? What do you think they're going to come to the hospital looking and sounding like?
Wheezing.
Wheezing, not being
Maybe. Well, actually, they probably may not be too wheezy, okay? Because if that pleural space is being closed with fluid, you probably won't hear much along the lines of sounds because it'll be muffled.
Oh.
So you might have an absent lung sound, okay? Are they going to have difficulty breathing?
Yes.
Probably going to have some difficulty breathing. Their respirators might be elevated. What about the oxygen levels?
It'll go down.
They're probably going to desat a little bit. They're probably going to be very anxious. One of the cardinal signs of when patients are having difficulty breathing is anxiety. Think about it. I know it's kind of warm in Texas, but have you, I guess I'm not the only dummy who's done it. Have you ever put a sweater over your head and realized too late that you probably got it on wrong?
Yeah.
Or you can't find the head hole, and you start to wig out and panic a little bit.
So I hate hoodies.
Right, or when you put your hoodie
pullovers.
on and you put it on, but then the hood's turned the wrong direction. So that usually will ensue if you have difficulty breathing. You begin to panic. It's just a natural effect. You start kind of having panic and changes in behavior. Okay. Okay, that's all I want to say about the lungs. And what's the what is the purpose of the lungs? What our lungs do? What's their purpose?
For
They bring
oxygen.
oxygen to the blood. They work
Okay, so
with
they
heart.
bring in,
Oxygen
they
to the
pick up.
cells in the brain.
Absolutely. So what kind of air comes in? What kind of air is it?
Wait, oxygen
Oxygen, absolutely. And then what
Oxygen,
goes
yeah.
out?
and carbon dioxide goes out.
Carbon dioxide goes outside. Absolutely.
Yeah.
Absolutely. Okay, let's talk a little bit about the word respiration. The word respiration is just the exchange of gases between a living organism and its environment. That's all it means. Exchange of gas between a living organism and an environment. Do plants have respirations?
Mhm.
Yep.
They do, because what do they take in?
CO2.
Carbon
They take in
dioxide.
CO2, and what do they give off?
Oxygen.
Oxygen. So we have that mutual, beneficial relationship. They give off what we need and we give off what they need.
That's right.
Dr. Ross,
Yes, ma'am.
Emerald says she's trying to get in. Her computer was trying to restart.
Oh, okay. Okay.
Excuse me, Dr. Ross.
Yes.
I keep it's crackling, breaking up, so I'm gonna log out and log back in.
Okay. Okay. Yeah. No. Some of you guys I see are kind of glitchy, so it might be just maybe because of weather.
Yeah,
So,
we had bad weather this morning.
yeah.
It's supposed to be
My
another
internet was
storm
down
coming
at like
through.
7 a.m.
Oh, okay. Well, it's still being recorded, so you always have that. And also, as I reminded you guys earlier, sorry to come off the topic, the pharmacology for last week is still being recorded because it's such a long lecture. So parts 1 and 2 are up. So I only see a few of you guys have popped in there. Please go in there because it is a lot of information, and that infection or anti-infective exam can be challenging. So make sure you're going in there, taking notes, rewinding, but it is a lot of information. I'm not going to lie. So make sure you guys are going in there because that test is going to be a little bit more challenging to you. Okay. All righty. So let's get back onto respirations. Okay. Let's get back onto respirations. External respirations or breathing. External respiration occurs from the exchange of the living being from oxygen to CO2. Or CO2 or oxygen if you're talking about plants. But let's talk about human beings. The external respiration is breathing. When we breathe in oxygen and we exchange it with carbon dioxide and we breathe out absolutely CO2. So that is external respiration. That's me doing.
That's external.
That is correct. Okay. But we also have a process called internal respiration. We also have a process called internal respiration rather. And that occurs at the cellular level. That occurs at the cellular level. So that's the exchange that occurs in the alveoli or the alveolar capillaries, where they themselves change oxygen to CO2. Change oxygen to CO2. So you see we have two forms of respiration, one at the big level from the nose and the mouth breathing in and the nose and the mouth breathing out. And then we have internal respiration that occurs at the cellular level inside the body of oxygen becoming CO2. Oxygen becoming CO2. You guys picking up what I'm putting down?
Yes.
So you guys could explain the difference if I gave you, say, a little Kahoot quiz in a few minutes, right?
What? Yeah.
Okay, good. All right, good. I'm just saying.
Dr. Ross,
Yes, baby.
I have a quick question. I know the external respiration is just like regular breathing, but with the internal, could you give like an example of that? Is that like a ventilator or something?
No. A ventilator would still be external respiration because that's from the outside to the inside. Internal respiration is what occurs at the systemic level within the blood. So that's going to be exchange in those capillaries. Remember we talked a little bit about those alveolar capillaries, how it goes from oxygen to CO2?
Yeah.
That's internals.
Oh, okay.
So is it like basically saying if we don't have internal respiration, we can't have external?
The other way around. If we don't have external, we don't have
have
internal.
Okay.
That is
Oh, okay.
that is correct. All right. Coming together, y'all. It's coming together. What part of the brain helps to regulate breathing?
Medulla, I
The
guess.
There you go.
medulla.
It's on the,
Medulla.
it's on the screen. It's on the screen. The medulla.
Oh, the
Y'all are
medulla.
so smart. How did y'all know that?
You just
it's
Y'all
right
just
there.
guess because y'all so smart. I know.
I read about it somewhere.
Awesome. But the medulla is responsible for respirations. That becomes very integral, especially when you start dealing with patients that have head injury, stroke, cerebral vascular accidents, and all that other crap. So if they are unable to maintain their breathing rhythm, where's the stroke at, guys?
Your medulla.
Probably somewhere in the medulla. Okay. Is that pretty serious?
Yeah.
Yes.
That's pretty serious, ladies and gents. If they're having difficulty maintaining oxygen and rhythm and having irregular rhythms because of a cerebral accident and that medulla's involved, you got to get on it. You know, I mean, even if you know, chances are that's an ICU, you'll be doing it more as an RN. But, you know, if you're taking post-op care of a patient and they're in LTAC and you have them, then you know they've had some sort of cerebral accident at the medulla. I got to watch this guy. I got to watch this cat because it might be some respiratory issues. I need to monitor his O2 sat closely and his respiratory rate. Picking up what I'm putting down? And rhythm.
Yes.
Yes.
Right, good job. Good job. Okay, so let's take a look at ventilation, or external or pulmonary ventilation, same difference. Now, remember I told you that the lungs sit on that muscle called the diaphragm, right?
Yes.
Okay. Remember I said it sits on the diaphragm. The diaphragm flattens with expiration. So you see, this is the diaphragm here. So you see it goes down as you expire. So do it to yourself, right? You guys can kind of feel under your chest. When you breathe out, the lungs go down. The diaphragm goes down. Does that make sense?
Mhm.
Okay. But as you breathe in, the diaphragm goes up. So everybody breathe in. That diaphragm goes up. So flattens for inspiration and curves for expiration. Okay. Is respiration controlled? Is it a voluntary or an involuntary function?
Involuntary.
Involuntary.
No, not involuntary.
It's voluntary.
Can you control your
Oh.
breathing?
Yes.
Oh yeah, you can.
I mean, you
control your breath.
can.
But you can't be without it at the same time when you go to sleep or even just anything. It's just
Right. Now, when I'm saying voluntary, I'm not saying that every time you breathe, you got to say, oh, breathe, dummy, breathe, dummy. No, that's not what I'm saying. But when I'm saying, I mean, is it controlled? So like your heart rate, you can't control your heart rate, can you?
Right.
Not directly. Now, if you run up and down the stairs, yeah. You know, if you smoke a cigarette, yeah. But you can't tell your heart, beat slower, beat faster, beat slower, beat faster. I mean, there's some, you know, Zen masters and yogis and things like that who can do that. But for the most part, the average Joe Schmo cannot tell their pulse to slow down, their heart rate to speed up, can't tell their temperature, ooh, get hotter. You know, you can't do that.
Right.
But for respirations, for the most part, we can control how we breathe, right?
Right.
Yes.
We can control it, okay?
Except
Also,
when we breathe, when we sleep.
except for when we sleep. Except for when we sleep. Now, it does have an involuntary mechanism built into our respirators. So, for example, have you guys ever heard of sleep apnea?
Yes.
Yes.
Okay, so now what happens sometimes in sleep apnea is if a person is overweight, maybe they have a thick neck, a large tongue, things like that, and they're laying flat, you're going to stop breathing. You'll have a cessation of breathing for about 20, 30 seconds. Your body is automatically going to kick in response to being hypercapnic. So if that CO2 level gets too high, your body, your medulla, is going to overrule and say, uh-oh, she's hypercapnic. She has too much CO2. I got to get this stuff off. Let me kick her in, and make her start breathing. And sometimes it'll jostle the patient, wake the patient up, or the patient may snore. So that helps that patient to start breathing again and jump starts that breathing. Okay?
Dr. Ross,
Yes,
but that's not only like overweight people. My dad was slim and he had sleep apnea as well. Like
right,
his
but
whole
those
life
do
he would
the
stop
talk.
breathing and we would like hold our breath waiting to hear him start breathing again. And he'd like start gagging and
But
choking.
usually that's going to be the cause. So even if he wasn't big, perhaps his neck might have been larger than for his trachea. Sometimes that does happen. Sometimes it can be post-stroke. So if a patient has like cerebral damage to the medulla or any of those respiratory centers, it can induce apnea. Okay, but you will most commonly see it in patients that do have a larger size neck. Perhaps they are a little overweight, perhaps even heavy boobed. You know, if you have a lady that's heavy chested, when they're laying flat, sometimes that does happen. Okay, but it's, you know, there's always excuses to the, excuses to the thing, but we look at what's the most common causes of things. Okay.
Okay.
What else did I want to say? Okay, also, in addition to the diaphragms moving up and down, you have intercostal muscles that sit in between the ribs. Does anybody eat ribs at barbecues?
Oh, yes.
Yep.
Oh yeah, absolutely. Now, if you kind of get to the down and dirty of what a rib is, when you look at the rib, you have the bone, right?
Mhm.
Around the bone, you have meat.
Mhm.
That meat, we have it too, are called
Yep.
intercostals. Those are called your intercostals, okay? So let's look at this person here. I don't mean to be macabre, but it is what it is. All around these lungs, we have this intercostal tissue, and it too contracts and relaxes to help move the lungs. Does that make sense to you?
Mhm.
All right, good job. So next
The
time you're
tissue,
at the
is it
cookout, you're
muscular?
eating your ribs, you can kind of impress your people and tell them you're eating intercostals.
I have a question.
Yes,
Is the tissue muscular?
it is muscular.
Okay.
Absolutely. So you can impress your family members and tell them you're eating intercostals. I know, gross, right? You're eating cow or pig intercostals. Okay. So this is just a little quick demonstration of the mechanism of breathing, and it makes it more of a primary understanding, but I do think it's absolutely poignant. So let's say we had this wonderful glass container and the lungs are inside. As you pull the diaphragm down, the lung pulls down, and what happens to the air?
It comes in.
Fills up.
Goes in. As you release the diaphragm, what happens to the lungs?
The
It
air goes
pushes
out.
out, expels out.
Closes in, air comes out. Absolutely. So that kind of gives you just an idea, a visual of what breathing actually looks like, the mechanism of breathing itself. Am I losing anybody? All righty. So let's go ahead and put homeostasis into the mix a little bit. And what was homeostasis, ladies and gents?
Balance.
Balance.
Everything is balanced, right?
Balance, absolutely.
Turn on that stuff.
And your lungs look to maintain balance. So if you were to hold your breath, talk to me about what's happening with air inside your lungs. And I decide to hold my breath.
Too much CO2 building up.
Too much CO2 begins to build up. So it's not so much like, if you know how well, I don't know if they really do that anymore because kids are a little strange. But back in the day, kids would call themselves being upset. I'm gonna hold my breath until I pass out.
Yeah.
Good luck with that, Sparky, because what'll happen is you'll have high levels of CO2. It is
When
not
you pass out, you start breathing.
you'll start breathing, but you'll probably start breathing before then. But the reason that you get lightheaded is not because your oxygen level is too low. Normally, it's because your CO2 levels are too high. Now, there are disease processes where the opposite is true, and we'll see that in our COPDers, and you'll learn that in med-surg, where normal people, I don't want to say normal because COPD person is a normal person, but a person without COPD and emphysema, they breathe on what we call a hypercapnic drive. So the reason that we take our next breath is because CO2 is increased. Does that make sense?
Yes.
So as CO2 increases, that tells your body, tells your medulla, all right, dummy, take a breath. Release some of that CO2, take a breath. But in our COPDers and our emphysemas, they breathe on what we call the hypoxic drive. So they take their next breath based on oxygen levels decreasing. Does that make sense to you?
Yes.
Okay, awesome. So our body likes to maintain homeostasis. So as there are demands for oxygen, we will begin to breathe in. Anybody go for a jog lately?
No.
In this pandemic? So that means y'all need to be out there jogging. Okay, y'all go and put on the ear pods.
I'll do a brisk walk. I'm not jogging.
Who said brisk walk?
I'll do a brisk walk.
Who's that?
Me, Nakia.
Oh, Nakia. Okay, so when Miss Nakia does her brisk walk, she getting away from her kids. She thinks she's slick, but that's
exactly what I'm doing.
There you go. So when she does her brisk walk, ladies and gents, let's talk to us about what is physiologically happening in her body. She's doing that brisk walk. What's happening to the respirations?
She is increasing and
Getting stronger.
Why is she increasing in respirations? Why does she have to breathe faster?
Because she's moving harder. Her cardio rate is going up as she's moving faster. So now her respirations are going up.
She
Absolutely.
needs more oxygen.
Who said that?
Peggy.
Becky, there you go. Talk to me, Becky. Now we in the right train. Why does she need more oxygen?
Because her body is expending more energy.
Yes, baby girl. Yes, yes, yes. She is expending more energy. So to compensate the demand for oxygen, Miss Ralph is going to have to breathe in faster. You picking up what I'm putting down?
Yes.
And not only will she have to breathe in faster, she's going to have to breathe in harder because she's got to get more oxygen in. You picking up what I'm putting down?
Yeah.
And as she's putting in more oxygen, as oxygen increases, what also increases?
Your heart rate.
Not heart rate, but what gas?
Oh,
CO2.
CO2. CO2. So as oxygen is increasing, CO2 is also increasing. So she's got to breathe off that CO2, correct?
Yes.
Absolutely. So is it starting to make some sense to you?
Yep.
All right, you guys are doing it. You guys are doing it. So under normal conditions, what is normal respiration rate?
12 to
12 to
20.
20.
in the book it
12
says-
to 20, 12 to 20. Absolutely. So we want to keep it at 12 to 20. When will it be higher and you not panic? What could be going on and it be higher and not panic?
You're hot.
There we go.
Exercise,
Who said that? Who said that? Becky?
exercise, sexual activity.
Okay, so exercise is chances are it's going to go up. Sexual activity, if you're engaged in a horizontal mambo, chances are it's going to go up, right? It'll go up a little bit, right?
A panic attack.
A panic attack. So if you're worried, panic, yeah, your respirators are going to go up. It makes sense, okay?
What if you're hot?
If you're hot, especially if you have a temperature, because if
Right.
you have that temperature, your body's instinct is to circulate more blood around in an effort to cool it down. Does that make sense to you?
Yes.
All righty. When would you not panic when it was slow?
When
Wait,
you're
say
sleeping.
When you're sleeping, it stands to reason that your respirators are going to go down when you're sleeping, right?
Yeah.
All right.
Meditating.
Say what's that?
Meditating, relaxing.
Meditating, because you're in that zen, right? You're in a very calm, copacetic mood, so it's going to slow down a lot, right?
Oh,
no-
another one where you can be breathing hard and you're not freaking out is like dancing, maybe.
Okay, dancing, because it's exercise, right?
Yeah.
What about some medications that it can increase heart rate?
Yes.
Oh, what about food like caffeine?
Caffeine, definitely.
Caffeine.
So if you drink those monster drinks, or you drink one of those 5-hour shot or whatever the heck they are, 4
Take
hour,
you some of
whatever,
that phentermine.
2-hour shot. Say again.
I said, take you some of that phentermine.
No, definitely don't take that from me. But if you take, oh, please don't take that stuff. But if you're drinking coffee or monster drink or whatever those things are, it's going to increase your heart rate. And just like Miss Becky said, medications, phentermine, any kind of diet medication. The reason that they increase your heart rate is because they're working to increase your metabolism. Don't take them, guys. I've seen so many patients working CVICU, young girls coming in. I'm wondering, why are these young girls coming in with all these heart attack and irregular heart rhythms? Messing with them diet pills. Because they speed up the metabolism. And in the interim, your heart is only designed to do two things: beat faster and get bigger. And if it's beating faster, it's just like your heart is a muscle. What do you do if you lifting weights with your arm and you're constantly doing that? What happens to that muscle?
Inflaming the muscle.
It not inflames, but it gets bigger, right? That's
Bigger.
what bodybuilders do. They constantly pump iron so that muscle to get big. Same thing happens with the heart. If the heart is beating faster for long periods of time and intervals, it's going to get bigger. So no phentermine, none of that diet pill crap. Okay, don't take any of those things.
Yeah. Or drugs.
And drugs too. Cocaine, crack cocaine.
Yep.
What's that other? Bath salts. That stuff is
Bath
bad. Have
salt.
y'all seen that bath salt? That stuff is bad.
Yep.
Ooh, that's a scary thought. So any of those uppers that are going to have you going speeding. Also, if you have asthma and you take a bronchodilator. For those of you with asthma, if you've ever had to pump up, and use your albuterol, what does your heart do?
It goes faster.
It goes fast. What happens to your respirators?
It gets faster.
It gets faster and rapid, right? Now that's expected. I wouldn't wig out. That's expected, okay? All righty. So let's talk about some irregular breathing patterns. Let's talk about some irregular or normal breathing patterns. Also, one thing I also want to point out, when you guys are taking your exams, be very careful for the normal questions. And the normal questions always trick you guys up, because when you're taking a nursing school question, you always assume something's wrong, right?
Right. Or
But-
more than what it is supposed to be.
More than what it is. Sometimes we ask you questions where ain't nothing wrong with the patient.
So simple.
It's so simple. You know, it could be something like, if I told you, I'm gonna give you, I know I'm off the topic. You guys are monitoring a patient and the blood pressure is 119/80, respiratories are 15, heart rate is 87, and temperature is 98. What's the first thing you do? Y'all just
Normal.
want to do stuff.
It's normal though.
But it's
It's
normal.
a normal patient.
It's a normal patient. So you might just want to monitor the patient, you know, but y'all already want to call a doctor, give them a medication. You always want to do something. So be mindful. You know, everything is not abnormal. Okay. So let me go into breathing patterns real quick. So eupnea, guys, is normal breathing. Eupnea is normal breathing. EU in Latin means good. So anytime you see EU before something, that chances are means normal. Good. We're doing okay. All righty. Hyperventilation. In hyperventilation, you're going to see rapid and deep respirations. When would somebody hyperventilate?
When they're scared.
When they're scared or anxious. They're breathing rapidly and they're taking good, deep breaths in. What about if they're in respiratory failure? They can't breathe. They're going to try to take rapid
Hypo.
labor. Say again.
Labor.
In labor.
Someone in labor, absolutely. Because during the time of labor, that mom needs as much oxygen in as possible. Okay, because oxytocin
strength.
needs to hit in, they need their strength, their muscles are contracting, those muscles in turn need oxygen, so they're going to be breathing rapidly and deep. That is hyperventilation. On the inverse, we have hypoventilation, where we have slow and shallow respirations. When do you think you might see some hypoventilation going on?
Sleeping.
Sleeping and bad sleeping, right? What about if patients if death is imminent?
That.
Okay, so if you have a dying patient, death is imminent, you may see them go into some hyperventilation before they go into other irregularities, and I'll talk about some of the irregularities in a bit, but you may see them go into slow, shallow respirations. If anyone's had a loved one or a friend passed on, you might see them starting to go into those shallow kind of breaths, where they're taking those little sips of breaths. Okay, then we have dyspnea, and dyspnea is labored or difficult breathing. Labored or difficult breathing. We also have apnea, where we have the cessation of breathing. Patient stops breathing, and it doesn't have to be forever, because we can have periods of it, right? As in sleep apnea, medication-induced apnea, or just plain old apnea, and they're gone from us. And then what's respiratory failure, guys?
Failure to breathe.
Failure to breathe. Serious?
Yeah.
Heck to the yes. Okay, so how do we mitigate respiratory failure? We got to assess them first. We're checking out 2 levels. We can be checking some respiration rates. We're checking
Heart rate.
2 areas, heart rates. Do these people need ventilatory support?
Yeah.
Yeah.
Absolutely. So do we need to bag them? Is this a CPR situation?
Yes.
Yeah.
If they are unresponsive, absolutely. So this is where we're going to do our CPR. We're going to do our airway, breathing, circulation. We might have to do some chest compressions if they are unresponsive and we don't feel a pulse. If we get them into the hospital, these patients might have to have an oral airway, or they may even have to be on a vent. Okay. What may cause a patient to go into respiratory arrest? Talk to me about that. What might be a cause of it?
Shock.
A heart attack.
Shock, a heart attack, especially shock, right? But a heart attack, definitely. What about stroke?
A stroke.
Stroke, especially if they have a stroke to what part of the brain?
Medulla.
All right. All right, definitely. Okay. What about medications, drugs?
Yes.
Yes, like morphine.
Sorry, morphine, severe morphine. Who said that?
Me.
All right, see, Becky is on fire today, babe. So morphine, because morphine naturally suppresses the respiratory system. So if a patient overdoses on, or we give them a little bit too much morphine, we're going to suppress that respiratory system and we can send them into respiratory arrest. Okay?
A lot of pain medications are like that.
A lot of them, especially if you OD on them. So morphine, Vicodin, OxyContin, any of those, MS-Contin, all of those guys. Okay.
What Vicodin? I'm scared of that.
Yeah, Vicodin
I
scares me.
had to take
You know
that
what
after
also
my
scares me?
huh?
Ambien. You know what also scares me? Ambien.
Oh,
Why? Does it make you sleepwalk?
Woo! Ambien scares the bejesus out of
Yeah,
me,
me
buddy.
too.
That's some scary stuff. But it can too suppress the respiratory system, right? Because it's
That's
slowing
terrible.
everything down.
Dr. Ross,
Yes.
I have a question because when
Sure.
I was in high school, I knew a girl and she was young, and I don't know what she had wrong with her, but there were times where her lungs would collapse and she would need to go to the hospital. Like, what is that called?
I'm not sure. I mean, there could be several
Maybe
things.
she could have seizures or something.
I mean,
No,
if her lungs would collapse, I mean, that's anything. That she could have PCP pneumonia as a result of HIV. You know, she could have trauma. She could have sarcoidosis. You know, it's hard to say. It's hard to say. There's several, maladies that could be responsible for the collapsing of lungs.
so when it collapses, can they get it up and running, or is it
We
just
sure can, and we're going to talk about that when you guys are in med surge. We implement what we call chest tubes, and chest tubes will push up against it, and therefore increasing the level of pressure. But I'm not going to go into chest tubes right now because we're going to talk a little bit about those when we get to med surge.
okay?
Okay, so now let's talk a little bit about gas exchange and transport. Okay. Carbon dioxide, very important, ladies and gents. Hint, hint, wink, wink. Carbon dioxide in the cells is responsible for converting hemoglobin into a substance called let me say it right, carbaminohemoglobin. Okay, so once again, and it's on your screen for you, carbon dioxide that exists in the cells.
Carbaminohemoglobin.
There we go.
Because I see amino in there, so.
Oh, perfect. Carbaminohemoglobin. There you go. So it is responsible for the conversion of hemoglobin to carbaminohemoglobin. Okay. And then we know carbon dioxide moves out of those capillaries, circulates back through the blood, through the veins, and heads up to the lungs themselves, where it can pick up oxygen and repeat the process all over again. The way that cells get oxygen, and our cells do need oxygen, correct? The way that cells get oxygen is that it binds to the substance hemoglobin that exists in the red blood cells in order to bring it into the cell. So let's think critically about that. Hemoglobin exists in the red blood cells. We need hemoglobin in order for it to bind to oxygen to bring it into the cells. So
Yes,
if
for
we
gas
have,
exchange.
say again?
Yes, for gas exchange in the capillary.
But not for gas exchange. We're just bringing it directly into the cells themselves so that the cells can utilize
For energy.
oxygen. Now, ultimately, all blood cells are going to migrate through the alveolar capillary and yes, do gas exchange. But I'm just talking about the individual red blood cells themselves. So let's say we have a red blood cell. Let's pretend that this thing here is a red blood cell, right? This little drop is a red blood cell. It needs oxygen. In order for oxygen to come in and be utilized, red blood cells must have the substance called hemoglobin. Hemoglobin binds to that oxygen, and therefore the cell can utilize oxygen for all of its metabolic needs. Picking up what I'm putting down?
Yeah.
So what happens if a patient has low levels of hemoglobin, like our anemic patient, our iron deficient anemic patients? If they don't have enough hemoglobin, will the cells themselves have a lot of oxygen?
No, and you start getting heart palpitations, you start getting dizziness, even to the point of passing out.
Because inadvertently your body is being deprived of oxygen. Does that make sense?
Of oxygen and energy.
And energy. So how do our anemic patients look? They may be tired, they may be pallid or pale because they lack that hemoglobin and in turn the oxygen level. Can you see maybe some desaturation going on?
Yeah.
Okay, because they're not getting oxygen that's needed for those cells.
Yes.
Picking up what I'm putting down?
Yes.
All right, good job. Nah, I don't really want to, I did a lot of talking about this. I'm not good. not going to repeat myself. These are some terms I do want you to know. I do want you to know these terms. So go ahead and put a little star next to this information. I do want you to know these terms. Let's talk a little bit about these mechanical ventilatory terms. Tidal volume, ladies and gents. Has anyone ever had a pulmonary study?
No.
My asthmatics, you had to have if you were diagnosed with asthma.
Yeah.
They didn't do a study.
And they do that study and they have you breathe into that thing looks like a toilet paper roll.
Right.
It's a mechanical thing. You breathe into a toilet paper roll. So what it does is it's going to measure these terms. So the first one is tidal volume, ladies and gents, tidal volume. And tidal volume measures the amount of air that a person inhales during a normal breath. So they'll ask you, okay, empty your breath, empty your lungs as much as you can. And then breathe in, breathe in, breathe in, breathe in, breathe in, breathe in, breathe in. That kind of take.
Okay, I didn't know that was a study.
That is indeed a study. Yes, ma'am. And they'll tell you, keep breathing, keep going, keep breathing, keep breathing, keep breathing. They're going to measure how much oxygen, or how much air rather, you can take in a normal breath. Picking up what I'm putting down?
Mm-hmm.
All right. Then we have residual volume. They're going to tell you, take all the air out of your lungs. Just breathe out as much as you can. It then in turn measures how much air remains in even after you exhale. Because if you've exhaled as much air in as you possibly can, there's still going to be some remnant or some residual air in your lungs. Okay. And then vital capacity is a combination of the both. So vital capacity looks at how much did this person breathe in and how much did this person exhale. Picking up what I'm putting down?
Yes.
Okay. Do you want me to describe this in terms of numbers?
Sure. Yes.
Okay. So let's pretend, and I don't know how much actual volumes are, so I'm just going to give you some arbitrary numbers so that it kind of makes sense to you, right? So let's pretend for tidal volume. Tidal volume is the amount of air that a person inhales during a normal breath. So let's say the patient breathes in and they breathe in 100 milliliters of air. I don't know if that's a number, just roll with me, okay? They breathe in 100 milliliters of air. That's going to be the tidal volume. Then from that 100 milliliters of air, you ask them to breathe out as much as they can. And they breathe out as much as they can, but 25 milliliters remain.
Mm-hmm.
Okay, that's going to be the residual volume. The vital capacity is going to be the amount that they inhaled versus the amount that they exhaled. So remember, they inhaled 100, they exhaled 75. So the vital capacity is going to be 175. Does that make sense?
Mm-hmm.
Yeah, no? Because remember, 25 of it
Yes.
stayed in the lungs.
Wait, can you do it again one more time?
Okay, from the beginning?
Yes, ma'am.
Okay, tidal volume is the amount that you inhale during one breath. So let's say our patient breathes in 100 milliliters of air. I'm just coming up with some crazy number. Okay, so think about it. Say you have a balloon. That balloon fills up with 100 milliliters of air. Then you ask the patient to breathe out as much as they possibly can. So out of that 100, they exhale 75. That's all they can get out. So that means 25 of it remains. Does that make sense? Did I lose anybody?
No.
Okay, so vital capacity is the amount of air that you can breathe in and breathe out. Now remember, the tidal volume was 100. They could breathe in 100. Okay? They exhaled 75 because remember, 25 stayed in. So then what is the vital capacity, ladies and gents?
175.
175.
So you're adding how much they exhaled and how much is still in?
Nope. How much
How much they inhaled and how much they
inhaled.
exhaled.
You know, we don't
Oh,
work-
okay, I'm sorry. How much they exhaled and inhaled, you add all that together in vital capacity.
That is correct.
Yeah, sorry, I said it
That's
back.
okay. You don't include the residual. Remember, the residual is what stays in after they've exhaled all the air out.
Right. Okay.
Because if they exhaled everything out, then their lungs would collapse.
Yes.
So some has to stay in. Some air has to stay in. All right. Okay, I'm going to give you about a minute. Look at your notes, and then we're going to play Kahoot and go over some of this stuff. You might see this stuff again. I'm just saying, so you might want to pay attention. Okay.
Okay.
All right, so go ahead and start getting your Kahoot together and start looking over your notes. And I'm gonna pull up my Kahoot as soon as I can find it.
Oh, you can do it on your phone.
And let me turn the music down because that music is always loud when we start playing.
We have to open in the Kahoot thing?
So go ahead and open up a Kahoot.
Do it with my phone.
Yeah, you can do it on your phone, And your
Okay.
name today, I want you to make let's see, what would be a fun name? Fun name would be, your favorite fruit will be your first name, and a terrible X will be your last name. Favorite fruit is the first name, terrible X is your last name. Favorite fruit is your first name, terrible X is your last name. Let me turn that loud music off.
I didn't get the
What
password.
is a pen?
It's coming up.
Oh, there it is.
Yeah, the pen should be on your screen. Favorite fruit and terrible X. Favorite
Hold up, it doesn't give me that option. What?
Pineapple King. All right. That's actually a pretty cool name. Champion Dragon. He's a dragon or she's a dragon. Pineapple X.
Not working.
Right.
Strawberry Point. Strawberry Point.
Wait, are we doing our ex's name or?
Yeah, your ex's name. So favorite fruit is your first name and terrible X is the last name. We have Strawberry Robbie, Mango Phillips. That sounds like a rock name, right?
I don't see mine. I don't know. How do I change? It says Champion Dragon, but I did not type that in.
Oh, sorry. Well, here,
Hold on. I don't know how you guys are. Where do I go? It's not letting me.
Hold up. Let me try it again.
Okay.
118462. Enter. And then
Did you guys already sign up for this?
It's
just a website.
Go to Kahoot.it. Kahoot.it. Pineapple Rich.
Doesn't let me.
It's giving me crazy names like Space Bobcat. I didn't even put that.
Oh, okay. Maybe it's, go past it. It's probably giving you the crazy name generator. No, name generator.
Oh my God.
Papaya R. Blueberry Julio. That sounds like a band's name. Coming to the stage is Blueberry Julio. All right, Strawberry Mike.
What was the password?
The pin is on the screen.
Like, because I have to go in between.
Oh my God.
Okay, are we almost ready?
Hold up.
15. I think we're missing 2. Missing 1, rather. No, it should be 19 to 17. So yeah, we're missing 2. Okay, we're losing people. Y'all logging out? What y'all doing?
They probably changing their name.
Change your name, huh? you got a point.
I was trying to change my name. That was terrible.
Are you there? Okay.
All right, everybody ready?
1 second.
Okay.
All right. So.
Somebody came out again. Would y'all stay in? Stop logging out.
All
Okay,
right.
I'm starting the game. Y'all take too long. Y'all ready?
Yeah. I
Okay.
guess it wouldn't let me change the name. I don't know
Okay,
why.
just stay with what you what were you, Dragon Mango, something? Just stay with
No, it says Space Bobcat.
Space Bobcat. Just stay Space Bobcat.
All right. All right.
Okay, y'all ready?
Yeah.
Yes.
All right, let's get cracking.
Oh.
Okay, don't forget, answer correctly, my folks. This tissue moves in one direction and helps to bring bacteria back to the nose or mouth for removal.
Oh.
Look at the wording. It's worded a little different, but look at the word.
Can't see all of the answers.
You can't see them?
No.
Oh, so what am I doing? Hold on, let me make it a little smaller then. Okay, can you see it now?
I only see one.
You have to look at her screen for the answers.
I know, but I only see the blue one. The surfactant.
Okay, hold on, let me see. Can I make it smaller? Oh, that's bigger. That better? No?
I still don't see them.
Did you break it?
Probably.
Oh, man. Okay, but
Is your screen maximized?
Yeah.
Is the screen big?
Aw.
Okay, so the answer is ciliated epithelium. Remember, we mentioned that it is the cilia, those little hair-like appendages that push it toward the front, What were surfactant?
Surfactant is for the alveoli to stay open.
Right, it is that substance to keep the alveoli open. And what do we talk about, even though, get rid of that U, what do we talk about respiratory mucus? What do we say about that?
The upper respiratory.
Said it's all one sheet of material, right? All one sheet of material, okay? All right, so let's see who's winning. Peach D. All right, Peach D, let's keep moving. Which of the following is not a part of the pharynx? Woohoo, we got overwhelming correct. Woo, my baby's on fire. Go chicken nuggets. So the otopharynx, we didn't mention anything about the otopharynx. I just made that up. So what were the three? What's at the top?
Nasal.
Nasopharynx,
Oropharynx,
laryngopharynx. Good job. All right, strawberry point. Let's keep going. This paranasal sinus sits near the cheeks. We talk a little bit about this particular paranasal. Sits near the cheeks. Good deal. The maxillary. Where do the frontals sit?
Up here.
Of your head.
I can't see you.
Up here.
I can't see you.
Top of your eyebrows.
Right, by your eyebrows. Your eyes are. Good job. And where were your sphenoids?
Here.
Sphenoids.
In between your nose or your nose,
Your eyes and
forehead
your
area.
Good deal. Good deal. All right. All right, Strawberry Robbie. Let's keep it moving. This flap of skin prevents food from entering the trachea. All right, the epiglottis. Awesome, awesome. Remember, not the larynx. The larynx sits on top of, underneath the pharynx, right? Epiglottis is that little thing that's going to flap back and forth, okay, and prevent it from going into those lungs. All right, Space Bobcat 24.
Yes.
Moving. Sorry about the spelling. This term refers to, oops, I lost it, refers to the act of breathing. Active breathing. All right, that is external respiration. What is internal respiration?
Gas exchange.
Gas
Gas.
exchange.
Okay, it happens at the alveolar level. Let me just put an aside. A pneumothorax is an actual puncture or you know, some kind of disruption in the lung itself. So a lot of times it's a hole in the lung. Okay. All right. So just as an aside, I forgot I didn't mention that to you. All righty, Strawberry
Robbie.
Strawberry.
Who's that?
Moving on up.
Tippy.
This term refers to the blood, and my spelling is abysmal. This term refers to the blood entering into the lung after injury. Oh, my spelling is terrible. But let's kind of think about it. If a pneumothorax is a hole or air, what could be blood entering into the lungs? It is a hemothorax. I'm sorry for that spelling.
Oh, I didn't even think about that.
So we know pneumothorax is going to be a hole in the lungs, right? If blood begins to rush in, we have a hemothorax.
Right.
All right.
Hemo.
Good job, guys.
Yay.
You guys are awesome. This term refers to the collapse of alveoli. It prevents the exchange of gases.
I messed up.
Messed up? Get the wrong one. It is atelectasis. Who said pneumonia?
That's why I said I messed up. I tried to click the orange one, but I got fat fingers.
Now, atelectasis can, my spelling is atrocious. My God, let me go back in and correct this stuff. But atelectasis can lead to pneumonia, ladies and gents. So think about that. If atelectasis is the collapse of the alveoli and that surfactant and mucus stays in those alveoli, can you see it being a breeding ground for bacteria?
Yes.
You know,
yeah.
Breeding ground for bacteria can in turn cause pneumonia. So atelectasis, if not treated, can lead to pneumonia. Now, who picked surfacticitis? I made that up. That's not a word. That's not even a word, y'all. I ain't even mentioned that term in my lecture.
Will they put made up words on the NCLEX too?
No, not at all.
Okay.
Everything's going to be fact-based on NCLEX. This term refers to the amount of air a person inhales during a normal breath. Oh my God, my spelling is terrible. Let me go back and change this. It is indeed tidal volume. Remember, that's the amount of air that a person inhales with a normal breath.
Yeah.
So once they breathe out, what is the remaining amount of air called?
Residual volume.
That is the residual volume. And what is a combination of all air come in and out?
Vital capacity.
Vital capacity. All right, guys, you guys are good. All right, Strawberry Mike, staying on up there. This term refers to the amount of air, that remains in a person's lung after fully exhaling. The amount of air. Right, it is called residual volume. Fantastic, fantastic. And last but not least, this term refers to alternating periods of apnea and hyperventilation. Now, I didn't mention it, but if you did your reading, you would know. It's okay.
I don't know.
It's okay. It's okay.
Whatever she didn't mention, I just picked it.
Okay, Cheyne-Stokes breathing. Absolutely. I didn't mention it, but it is in your book. Cheyne-Stokes breathing, we call it a death rattle. It's usually right before impending death. So what will happen is that the patient may have little periods of they stop breathing whatsoever, and then they pick up. And it's very abnormal. We call it kind of like a death rattle. So usually death is imminent at that point. Okay. All right. Good job, guys. So let's see who won. Who's third? Strawberry Robbie. And number 2, Watermelon John. And let's see who the big winner is. Strawberry Mike. All right, Strawberry Mike, give yourself a hand. Good job, guys. Good job. Well, are there any questions before we blow this pop stand?
No.
Yeah, what's my prize for getting number 2? I mean,
You get a big clap. Well, number 2, you ain't say number 1, man. You ain't even win.
What about number 1?
Yeah, you want a prize.
What about number 1?
Number 1, you get an even bigger clap. Yay! You guys are awesome. Oh, also, don't forget, let me put it up here. Your 3-minute paper is going to be due online, so make sure you get your 3-minute paper on in there for you. Okay, and make sure you guys get this stuff on time, not on the weekends, because I'm out of pocket on the weekends. So try to get this stuff a little earlier than if it's something sentinel that you need. Okay.
The 3-minute paper is, oh, okay, never mind.
Yeah, your 3-minute paper. I just put it in here just to remind you, but you know, since we're not face to face, you can go ahead and do it and put it on in there. Okay. All right, babies. It was a wonderful, wonderful day seeing you guys. I'm gonna let you guys have a little bit of time back to go study, and then just log in for Mrs. Duhan when it's time for Mrs. Duhan. Okay.
Dr. Ross, will you double check the lecture number 2 for the anti-infectives?
I know. You know what happened? It never uploaded, so I redid it.
Okay.
Yeah, I redid it. So I'm hoping. Well, let me see. Did it actually finally think?
That's what I was gonna ask.
Yeah, because you
don't think it's still on there.
A little funky when they're large files. Let me see. Yeah, see, it's still processing. If you can see my screen, see, it's still processing. So hopefully it should be done pretty
And
soon.
Dr. Ross.
Yes, baby.
We never went back. Remember I told you my week 2 3-minute paper, it uploaded the template instead of my actual paper.
Why they do that?
Because my computer don't let me change.
Okay, let me look into it. Send me an email so I can take a look into it.
Are we able to send the 3-minute paper as a text? Because that's what I've been doing versus uploading.
I was going to.
Send it as a text to who?
It's in there. It says input right there as a text.
Oh, yeah. Oh, yeah. You
Okay.
can type it. Yeah, that's fine.
Yeah, I'm just typing it. Okay.
Yeah,
Okay.
that's fine. Yeah, you can type it. So part 4 is up and ready for you guys, and I put it in the pharmacology playlist, so you can go ahead in there and take a listen to it. And like I said, it's a lot of information, so sit somewhere with it quietly and take your notes and listen to my voice, guys. Listen to my voice. When I kind of inflect and stuff, that's some pretty important stuff that you might need with those anti-infectives. Also, have your book right next to you so that you can follow along very easily, okay?
Okay.
All righty, so it's a few more sections because I'm not quite finished with all of them because it's taken a long time to record. So as I post them, you know, I'll let you guys know, but just stay in the YouTube channel, you know, and just kind of look and see. And I always put the link in your Canvas, but you can always just play around in our YouTube channel to take a look at all the videos, okay?
Dr. Ross, when will the exam over that be?
Exam of what?
Of this week 4 pharma anti-infective.
You got to look on your calendar because it's a few of them. You're gonna have like anti-infectives, I think respiratory drugs, and like GI or something. But you got to look on your calendar.
Okay.
Because I'm not sure off the top of my head. All righty, beautiful folks. All right, you guys have an amazing day, and just be there and ready for Mrs. Duhan when her class starts.
Okay. Thank you.
Okay. Have a great day, guys.
Have a good day.
You too. Bye bye.
You too.
Bye.